Hi there. Welcome to this session of Harvard Update. I'm Kristin Schreiber. I'm an associate professor at Brigham and Women's Hospital in the Department of Anesthesiology, Perioperative and Pain Medicine. A little bit of background is that my PhD is in the neuroscience of pain and pain processing, and I do research in humans, both in the quantitative sensory testing lab and in the perioperative period, really trying to understand ways that we can reduce persistent post-surgical pain. I don't have any conflicts of interest that are really relevant to this talk. I do serve on some advisory boards and grant review and receive some funding from a number of agencies to study chronic post-surgical pain. So the objectives for my talk today are to give an overview of the biopsychosocial model of pain, what that is, to explain the concept of pain phenotype, so not genotype, but actually pain phenotype, and how this may relate to the variation in the risk of chronic post-surgical pain, to highlight some methods to measure elements of the pain phenotype in our individual patients, and lastly, to provide then a framework for applying this knowledge about the pain phenotype to inform perioperative preventive decision-making. So let's just start with this basic question. Why do some people experience more pain than others? Or in other words, why is pain even variable in the first place between people? The nociceptive pathway, as pictured here, is a relatively straightforward, simple pathway and not obviously variable or modulatable on its face. And nociception is a preserved sense evolutionarily because it provides detection of noxious stimuli with some fidelity, and this could support our survival as a species. But I would argue that modulation of the nociceptive signal may also be adaptive in an evolutionary sense, and so we kept some of these genes as well. In some cases, it's crucial to either downplay or augment the nociceptive signal in order to navigate through a potentially harmful situation. And as pain research has progressed, a more complex model of pain has emerged, viewing it more as a matrix than simply a pathway. So I'm going to go through this neuromatrix model to introduce some of the things that have been found to be important modulators of pain. And this is laid out as an input and output from our central system, inputs of nociception and outputs, things that we have to do to deal with it. So on the input side, we evaluate the salience and threat of a nociceptive stimulus cognitively based on our past learning. We discriminate harmful stimuli from other types of stimuli, other things that we can't afford to ignore. And our state of autonomic and inflammatory or even emotional charge can give meaning or interpretation to these incoming nociceptive stimuli. Now, at the same time, on the output side, we have to perceive what's going on. We have to be motivated by this. We have to discriminate things. We have to know what to actually do about this. We have to potentially have an action, whether it's voluntary or involuntary. And we have to provide some sort of framework for changing our physiology so that we can adapt to this and relate it to the future. So we regulate in our stress system to this. So the upshot of this is that there are many things that modulate pain, and this is something that we've learned from studying pain over time. Now, one extremely confounding question evolutionarily is why someone sometimes gets persistent pain. Why would an acute injury lead to persistent pain? It doesn't seem to serve any purpose. Acute pain is probably functional, but chronic pain is really quite maladaptive. And I started out as a neuroscience grad student in a spinal pharmacology lab where we were trying to understand the mechanisms that were underlying this pathophysiological plasticity event that led to the development of chronic pain. And of course, in our animal models, we could implement preventive interventions because we had control over the experiments. But in most chronic pain in humans, you're coming in after the fact, after the injury has occurred. So I was really drawn to the idea that there was a type of chronic pain that I could potentially prevent since it was scheduled ahead of time, and that's surgery. So persistent post-surgical pain, I really saw as an important opportunity to translate some of what we had learned preclinically in the lab to humans. So this table shows the range of reported incidents of persistent pain after different types of surgical procedures. And you can probably appreciate that the range is quite wide, depending on the study, mostly because it's variably defined what chronic post-surgical pain is. But even if you're kind of very discriminative and you say that person has to have a severity that's quite high, when you consider how many of these surgeries are happening each year, that's potentially a lot of new chronic pain patients each year. And add to that the fact that 80% of patients receive some sort of opioids during or after the surgery. And some evidence suggests that people actually do develop chronic opioid use as a result of receiving opioids during their surgery. Now, hopefully this is getting better. But all of these things together really underlie this importance of chronic post-surgical pain. And the IASP, in fact, in 2017, sort of named that year as the Global Year Against Pain After Surgery. I certainly think it's an important thing. But when approaching this question, I found that there's a basic reality that has to be navigated, which I'm going to highlight here. So while it's a goal to reduce acute pain after surgery, as I said, it's arguably normal and perhaps functional to have some pain in order to encourage rest and recovery. And the majority of patients, in fact, do not go on to develop persistent pain. Depending on what study you're looking at, this is about 70% of people. So that's great, actually. But it's really the smaller proportion of patients whose nervous system somehow undergoes a pathophysiological plasticity event that we're concerned with. And of course, we want to answer these questions. Can we interrupt this? What are the best methods to interrupt this? I mean, we're anesthesiologists. We potentially have access to someone's nervous system, and we can interrupt this, right? But I would argue it's more important to answer this question first. Who will this happen to? Most subjects, as I said, don't go down this pathway. And so if you study everyone, you're potentially going to get the wrong answer 70% of the time. And I think this might be what underlies many of our previous interventional studies being negative, which I'll get into in a little bit. So what I decided to do is really focus on this question first and build a good prediction model to who would undergo this type of transition. Now, one question that comes up a fair amount when we're talking about understanding differences between patients is why not just use their genotype, right? You look at someone's genes and this will tell you whether or not they're at risk for chronic pain. While there are some studies that suggest there are genes that are related to acute postoperative pain, including neurotransmitter pathways and metabolic pathways for analgesics. Unfortunately, this is really only known for acute pain and opioid use. And when you look at it all together, it explains very little of the variance seen between people. So it doesn't really add to the prediction so much at this point. I would say it's an exciting area of research and is continually evolving. So we'll stay tuned on that. Certainly at this point, there's not much at all about what predicts chronic post-surgical pain. However, in the meantime, there's a simpler way to access the variation that is related to genetic variation in the many genes that we know contribute to nociceptive processing. And this is the biopsychosocial model of pain variation, which I'm going to go through. So this model really recognizes that biologic genetic expression is importantly shaped by the environment. That is the interaction of genes here on the x-axis and the environment on the y-axis interact in real life to result in a phenotype here, sort of at the intersection. And this diagram comes from Bill Maxner and Luda Dyachenko from some studies that they had been doing looking at factors that could predict the progression to a chronic pain state, in this case, temporomandibular disorder. But they essentially found there are two main phenotypes that seem to be associated with the propensity to develop chronic pain. The first was what I'm calling the psychosocial phenotype. That is, how anxious, depressed, or stressed people are place them at higher risk of developing chronic pain. Similarly, a person's biophysical phenotype, or how their nervous system responds to any nociceptive stimulus, could also put them at risk of developing chronic pain. So things like a greater inflammatory response or less inhibition of pain, more temporal summation of pain, which I'll talk about in a minute. All of these sort of phenotypic factors tended to be associated with the development of chronic pain. So the question of my own work has really been whether we can use the measurement of these pain phenotypes to help predict who's going to have greater acute pain and chronic pain after surgery. So we've been measuring aspects of the psychosocial phenotype, shown here on the left, and I'll give one example. So one example is pain catastrophizing. So it's sort of a psychological response to pain. The pain catastrophizing scale is a questionnaire that asks people to reflect back on times when they've ever had pain and rate how much certain thoughts about pain occur, including rumination about pain, magnification of pain, and feeling helpless in the face of pain. And this is quite variable between people if you ask them to say how much these sort of thoughts arise for them. And then you can calculate a pain catastrophizing score and use that to potentially explain some of the variance of these other outcomes. So we do this for many different aspects of the psychosocial phenotype, thanks to some great collaborations with our psychology colleagues who have found good ways to measure these constructs. On the other side, we measure aspects of the biophysical phenotype through quantitative sensory testing, that is, actually applying a known nociceptive stimulus and seeing how people respond to that. So the example that I'll talk about, because it ends up being important in some of our work, is called temporal summation of pain. We take a weighted pinprick and we apply it over someone's finger. Now we do that 10 times in a row. The stimulus itself doesn't change, but someone's perception of how painful it is does change. It's almost like the nervous system doesn't have a time to go back down to baseline. And for some people, this occurs more than others. So in a way, it's an assay of wind-up or central sensitization, which takes about 30 seconds to do in the pre-op clinic. So again, we're taking aspects of the psychosocial phenotype from questionnaires and biophysical phenotype from these brief QSTs and asking how much they can predict persistent pain. Now, are people really all that variable on these things? I would say yes. So this just shows the range of variation that we see in various aspects of the psychosocial phenotype. So this is 250 women who are coming for breast surgery, and we have them answer these questionnaires, and these are their total scores, and you can appreciate how large the range of scores is. Similarly, when we do that temporal summation of pain test, the pinprick probe on their finger, you can see for some people, it really doesn't go up that much. So they have a temporal summation of 0, whereas other people, it will go from 2 to 10, right? They have a high temporal summation of pain. So we capture these this variation in the psychosocial and biophysical phenotype. So can measurement of the patient's pain phenotype before surgery actually predict postoperative pain? I'm going to show some of our findings in a couple of different surgical cohorts. So in this first study, we prospectively tested 250 patients who were undergoing total knee replacement, measuring the variation in their psychosocial and biophysical phenotype before their surgery, and then afterwards looking at their pain scores in the postoperative period. So on the left, we show quite a variety of postoperative pain scores. On the right, we have a variation of the total opioid consumption in the postoperative period. So then we did a multivariable regression to assess which of the factors that we measured before surgery could predict the variation in outcome that we saw. One note about multivariable regression, of course, is that you're taking all of the factors kind of together. So even if they're related, you're asking which one of them independently predicts, even taking all the other things together. So this shows the independent predictors of both worse pain severity in the green circle and greater daily opioid consumption in the blue circle. And you can see that women had greater pain if they were having a repeat surgery. Also, if you were younger, had a higher BMI or a longer tourniquet time, you had a higher postoperative opioid requirement. But the thing that's striking is that temporal summation of pain, this biophysical phenotypic predictor, was actually an independent predictor of both outcomes. So doing this one simple preoperative quantitative sensory test was pretty good at predicting both of these outcomes. Now, you might wonder where some of the psychosocial predictors are. The interesting thing is that we did a separate analysis for both men and women. And what we found is that anxiety and depression actually were good predictors for men, but not for women, despite the fact that women had higher anxiety and depression scores and higher pain scores. I think this really underscores the importance of analyzing data in different subsets of patients and how different aspects of a patient's phenotype may impact their assessment. In the next study, which formed the basis of some of my previous K23 work, we investigated post-mastectomy pain. And again, we're prospectively measuring variation in the psychosocial and biophysical phenotype before their surgery, and then looking at their postoperative acute pain. You can see, again, it's quite variable, as was the amount of opioids that they needed in the perioperative period, and how many people were actually taking opioids for surgical pain at 2 weeks. It was a minority, but 30% of people said, I'm still taking some opioids. And so we wanted to know, again, what of these preoperative factors, including aspects of the psychosocial and biophysical phenotype, could help predict this variation in outcome. So we used, again, a multivariable regression approach. And again, the independent predictors of pain are in green and opioid use in blue. Again, we see that temporal summation of pain is an independent predictor of both more severe pain and greater opioid use in our breast cancer surgery patients. Similarly, some of the psychosocial factors, including positive affect, depression, and also some demographic factors like less education, younger age, were associated with greater opioid use. So really using aspects of the biophysical and psychosocial phenotype could help explain some of these acute postoperative outcomes. But of course, we ultimately were more interested in predicting which animals would go on to develop persistent pain states. And although acute pain is related to persistent pain, and in fact is in some sense a good predictor of it, we wanted to know whether any of the baseline characteristics could predict persistent pain after surgery and whether they were the same as acute pain. So similar to the variation in acute pain, we did see a variation in the amount of pain individuals have over time. And so this shows the incidence of chronic pain in the first year after surgery. And this is sort of dichotomized as having chronic pain versus not. And you can appreciate that depending on where we put the cutoff, you have a different number of people who are reporting persistent post-surgical pain. And this is often how people have defined chronic post-surgical pain. We actually took a slightly different approach in order to do our analysis in this case, where we looked a little more exactly at how much pain people were having and how frequent it was. So we asked people to rate whether or not they were having any pain, and if so, where they were having it, what was the severity at each of the places, and importantly, how frequent it was. So if it was just very occasional, they got a lower score. If it was all the time, they got a higher score. And we rolled this into a pain severity index, the formula of which is shown here, essentially giving us a more sensitive analysis of how much persistent post-surgical pain someone has out to 12 months. We call this the pain severity index. It's actually a scale that was adapted from Henrik Kalitz's group, and we used in Pittsburgh and Boston, and now in collaborations with NYU, Duke, and Brigham. But as you can see on this graph, when we do this, we get a better resolution of the degree of variation. Each dot is an individual patient. You can appreciate that there are still a lot of people at 12 months that aren't having a lot of sort of pain severity, but there's a group of these people who are suffering quite a bit. Similarly, we also specifically asked patients to rate the degree to which their surgical area of pain impacted their functioning. So on the left are ratings of impact of surgical area pain on their cognitive and emotional functioning, and on the right, impact on their physical functioning over the course of the first year. And again, like the pain severity index, it's quite variable how much it impacts people, and it can be measured on a continuous scale. And this is important because it really allows us to do a more sensitive multivariable regression analysis. So again, we're trying to look at what are the predictors of who's doing poorly at 1 year. So this diagram shows predictors of chronic post-surgical pain at 12 months after surgery. And again, in the green circle are predictors of severity. In the red are predictors of pain impact. And in the purple are predictors of a neuropathic quality of pain. And you might wonder why we used all three of these outcomes. In fact, all three have been used to actually define what chronic pain after surgery is in previous studies. And we thought it would be interesting to see how they overlap. And that's where the Venn diagram comes in. So essentially, predictors that are common to all three types of outcomes include one, surgical variable, axillary lymph node dissection, somatization, that is sort of the tendency to pay attention to physical stimuli and be disturbed by them. Interestingly, sleep disturbance at baseline, even before their surgery, and having any preoperative pain. So those are really consistent predictors. When we talk about some of the psychosocial predictors like pain catastrophizing or depression or negative affect, these were really better predictors of the impact that pain was having on people at 1 year and not so much the severity. And the temporal summation of pain score, which was such a great predictor of acute pain and opioid use, actually was only an independent predictor of neuropathic quality of pain. And I think this non-overlapping of predictors actually reflects what happens in the larger literature. Just depending on how people define the outcome, they may get different predictors. But in any case, we do feel like some of these different psychosocial and biophysical factors may help us discern who's going to have worse pain. So the last thing I'm going to do is sort of highlight how we can use one phenotypic predictor to look at who can benefit from a perioperative intervention. So one thing I'm going to talk about is catastrophizing. So in this study, in this analysis, we looked at an intervention that we commonly use in the perioperative period for breast cancer patients, which is regional anesthesia. So these were patients undergoing mastectomy. They either received regional anesthesia, typically a paravertebral or proximal intercostal block versus no block. And then we compared people who got a block and didn't get a block, but we actually stratified it according to low and high baseline catastrophizing. So what this looked like is at 3, 6, and 12 months after surgery, the amount of pain that people were having is shown on the y-axis. And among the people with low baseline pain catastrophizing, they're in blue, who either didn't get a block or did get a block, there wasn't that much of a difference. They actually didn't have that much pain to begin with out at these later time points. However, people who had a higher baseline pain catastrophizing, there actually was a difference. So in a way, regional anesthesia has a greater impact among those people who had higher baseline pain catastrophizing scores. And if you analyze this all together, you would conclude that paravertebral does not have a preventive effect for persistent post-surgical pain. But within this small subgroup, it is actually important. And this actually also went for the amount of opioids that people were using in the long term after their surgery. Now, thankfully, not a lot of people were using opioids in the long term, but certainly those with higher baseline pain catastrophizing were more likely to, but not if they had received a regional anesthetic. So in conclusion, I hope I've convinced you that acute and persistent pain is variable. You probably know that from your practice, but that's true of the severity and impact among the individuals that we take care of. That the psychosocial and biophysical phenotype that you look at and when you preoperatively evaluate a patient may help explain the variation in the amount of pain, and that you can measure this with relatively simple metrics. A careful assessment of someone's pain phenotype before surgery could allow identification of individuals at highest risk of pain persistence, discernment of who an intervention might make a difference for, and hopefully help us target our prevention and treatment so that we don't actually throw the baby out with the bathwater. And maybe even give us some insight into modifiable mechanisms. Perhaps behavioral interventions in the perioperative period would be helpful as well, and help us personalize pain treatment. So if we bring this into an overall approach to preventing persistent post-surgical pain, I think we really need to look at biophysical, psychosocial factors and use that to help us pick which things we want to do in the perioperative period, develop an individualized procedural risk stratification and plan, and hopefully prevent persistent post-surgical pain in those people that are actually at risk for it. So thank you for your attention.